national standardisation of job roles and pay bands, again, which we've touched on earlier. But does anybody want to add anything to that? Do you think, because I think personally Agenda for Change has been a disaster and potentially, who knows, but it could be the ruination of the NHS myself. That's my personal viewpoint.
They are looking at reviewing the Agenda for Change now and the banding, so yeah, that might change.
Who is they? Sorry, I'm going to throw questions back at you now because I can.
NMC and
LMC?
Yeah, NMC, the Nursing Midwifery Council, and they'll probably work with the Royal College of Nursing probably, and NHS England.
So would that encompass?
I don't know how far they've got. I've just read that recently.
Well, I think it's like we touched on earlier. There's been so many changes and cutbacks and disruption within NHS England. There's been a lot of delays, hasn't there?
Yeah. And they're looking at certainly the Band 5 nurses as well at their role.
Well, like I touched on before, if we go like line by line, job roles and pay bands. I think it needs to be standardised. I had discrepancies even within my own organisation, never mind what we find up and down the country. And speaking to a couple of people outside and throughout the day, we've still got a lot of areas where decontamination professionals or decontamination technicians, whether it's endoscopy or sterile services, they're paid Band 2. I don't want to take anything away from the domestics or the portering teams or even the logistics drivers. But like I said earlier, the level of responsibility that a decontamination technician has in comparison to those roles, it's just not comparable. One of the things that I said to my organisation, just to sort of hit home on what's required of a sterile service technician, you have, and you can correct me on the bandings here, a scrub nurse, Band 5, yeah? So you'll have a Band 5 scrub nurse who will know every single instrument in their speciality, so the orthopaedics, plastics. They'll know all the instruments, they'll know the trays like the back of the hand, but if you move them into a different speciality, they might not know every single instrument. But then you've got sometimes a Band 2 or Band 3 sterile service technician that will know every single instrument, for every single tray, for every single specialty within that organisation. And that's a huge level of responsibility. Those tray sheets are legal documents. They're signing to say that tray is fit for use and safe to use on a patient. That's a level of responsibility that your domestics, your porters and your logistics drivers just don't have. So you can't expect them to be on the same pay band. And I think, again, we probably don't pay them enough at Band 3, but it's a start. So having the national profiles that once somebody is fully qualified and they've got the nationally recognised competency signed off for a sterile service technician, I think that would qualify them for Band 3. I think we need to have that, and it needs to be uniformed throughout the UK, not just individual hospitals. We have started the ball with that. I touched on it earlier with the NHSE Technical Bulletin 2024/02, because it came out in March, then got kicked back by IHEM, I think it was. You weren't happy, so there were some amendments. I say John is just Mr. IHEM, so that's why I look at him when I say it. So there were some amendments. It was finally released in the second version in May 2024, and that gave us 5 years for organisations, NHS organisations and private organisations, to be compliant. So come 2029, when the CQC come round, if they start reviewing decontamination, they are going to be expected to be asking the questions, have you got, for certain bands, excuse me, registration with the healthcare science, which it asks for bands 6 and above to have that level of competency that you need to be a registered healthcare scientist. And they're going to expect that bands below that have got nationally recognised qualifications and competency frameworks. So it's a start, we're getting there. But like John said, throwing this out to anyone, because I've tried to have a bit of an open session, do you all agree that it needs to be a nationally recognised programme profile, and is there any objections to that?
I think we'd done this debate at CSC around about 18 months ago, Trevor Garcia was fighting the corner of the bulletin, there was at that time, a lot of negative feedback, about a cost, expense, employment, slightly different audience to yourself, potentially. But there was a lot of kickback at that stage. As things
I think one of the things we had, sorry, John, was I always call it the most dangerous phrase in the NHS, and all of you are going to know this. It's, well, we've always done it this way, why do we need to change? That I've heard that so many times in the NHS, and that came up saying, we've been doing this job for 20 years, why do I now need qualifications? And without going into every single detail of why, I think one specific incident that highlights why we need to do this was the HSSIB report from 2020, where contaminated instruments were being used in surgery. That was the report that sparked off the national investigation, which showed that there was a disparity in competency, there wasn't enough investment in decontamination, and there wasn't enough continuous professional development within decontamination. And that's where the NHSE technical bulletin was all derived from. And there was several, so NHSE, CQC were asked to do certain actions, and it was only NHSE that did anything, and their response was to produce the technical bulletin.
So I think everybody's in agreement with that then. That's a positive outcome. How do you feel we plot a career pathway without national standards? And I put it to you guys, if we don't follow the bulletin that Rob's highlighting, how do your organisations get your staff trained? How would you go it alone, especially with the CQC breathing down your necks? Any thoughts on that?
Band 2 technician, you said Band 2 technician take a lot of responsibility. But if you simply upgrade or even the qualification, it won't solve the problem. Quite often, there's a structure already in place. Band 2 technician, then band 3 team leader, then band 4 production coordinator, band 5 quality manager, band 6 deputy manager, and band 7 or band 8 manager. So if you upgrade band 2, that means it will affect the entire chain. NHS, we already know that NHS completely broke. So if a heavy rain hit, few of our ward need to close because the roof are leaking. So when you present this case to the trust board, they won't agree with that because the patients, we always telling that patient safety is important, things like that. We coming the bottom of the list. So no money, that's a fact. And
it's
again,
not a fact, it's a perception.
Agree.
And you say trust boards won't accept it. I appreciate that there's definitely pushback from certain organisations, but you are seeing an increase in organisations that are accepting it because they recognise it. All the Manchester hospitals are doing it in London, and there's a couple more from around the country that have adopted. In your own region, one of your neighbouring hospitals pays band 3.
Yeah.
Where Swindon and Bath don't.
Can I come to that point? At one of our neighboring trusts, what they did, they reduced the number of employees and increased the banding. But we adopt a different approach because SSC staff always work under extremely pressure. So we reduce that pressure, increase the band 2s. So everywhere we got plenty of technicians. We are not pushing. They are extremely happy staff. And I mean, if you reduce the number and give band 2, we still need to process all the kit.
Well, I'm going to, for another, probably shooting my own argument in the foot here, that there's even pushback in some places, and I found it in Nottingham. There was pushback because in Nottingham we had what was called a fully flexible workforce. So everybody contributed to the full 6-2, 2-10, 10-6 throughout their working month. It was horrible, absolutely horrible. The ops manager ran it. I didn't agree with it, but the staff went for it. When we tried to introduce band 3s there, because at band 2 they were earning so much money on the enhancements, going to band 3 where the percentage payment is different, they would actually lose money by going up in a banding. So there is challenges. I think the national recognisation of the correct bandings, that's what needs to be done. And I believe that the bandings that we have in the old days and what we're still working with to overturn, they're incorrect for the levels of responsibility. We've done that within the Institute of Decontamination Sciences. Those job profiles have been nationally matched with healthcare science frameworks, with the healthcare science job profiles, so that your lab technician, your sterile service technician comes out at the same level. And then your supervisors, your operations managers, your production managers, your quality managers, your department managers, that's all matched with an already established healthcare science framework. And that's looking into that career pathway.
We looked into the career pathway. The problem is that if you introduce a structured career pathway and training, I mean, the three pathways are pharmacy technician, lab technician, and decontamination technician. So we provide all the training. They are qualified. What will happen? Pharmacy technician got band 3, band 4, band 5, band 6 technicians. Straight away, they move to the pharmacy technician or lab technician. They got various roles. But decontamination technician, only decontamination technician or team leader, that's it. So we got only band 2 and band 3. What will happen? We train all these people. They will go to other department. Why should we do that?
Have faith
21 years
that
I'm
you can
working
retain them.
So,
Some
and
people
again,
might do it because of the love of the cause. How long have you been in sterile services?
21 years.
21 years. You didn't leave. You, with all the experience, knowledge, skills, and qualifications that you obtained through that career pathway, you didn't leave.
That's not an easy pathway. I've been
I know
almost.
yours isn't an easy pathway.
I don't want any of my staff taking that much traveling.
And that's why we need to develop a more structured, logical, smooth career pathway, but recognise the responsibilities, the level of knowledge, and what they do at the correct pay points.
And again, last point. I will stop after this.
I'm liking this, so we keep going.
So
that just takes me back
the
years.
current training offering is not up to the mark. We provide better training in-house rather than any other current offerings. So then why should we pay? I mean, we got training managers, we got excellent training materials, we train our staff in-house. It will take minimum 2 years to completely train a decontamination technician from start to finish.
I think that the argument to that, and I do agree with you, there is a review of the academic material that's provided at the moment. There's been a further challenge, and again, I don't know if anyone's aware of this, that a lot of clinical apprenticeships have now been pulled from the levy. I was talking to somebody outside a minute ago about this. So if they're non-clinical, the levy's been pulled. So that was when the technical bulletin was written, everybody was being steered heavily to the apprenticeships, because that was a nice, easy, cheap way of getting people to the required level quickly and with as little disruption as possible. But now the government has removed that ability on the levy. It's created another gap. So we need to do something as an industry quickly. And I've already talked around with some of my colleagues within the Institute of how we address that and how we provide a more robust, logical education framework. And you say that we'd provide better training in-house. I don't disagree. There's some departments, I know from many years of knowing you, some of the great systems that you've put in. I can say that for my guys in Manchester as well. Our training manager has developed some excellent training packages. But the difference is that the ones that are provided externally, they've actually been levelled and matched by education or academic awarding bodies. And that's what's important, because things like places like the SQA, they are a European recognised qualification. So when it's been levelled, you can take that qualification anywhere and it stands. Your in-house training, it might be brilliant, it might be the best thing since sliced bread, but it's the same as your wash, it's not been validated, it's not been verified, and you can't use it everywhere. I couldn't take a certificate signed off by Sobi Joseph and walk into another sterile service and go, look, I am fully competent because Sobi says so.
So let's bring Sanna in on that, just for a different viewpoint. Sanna, what's your thoughts on obviously a national package, which, as Rob said, is validated, or potentially a robust in-house process?
Well, thank you. I am personally on the sort of national standardized role route, just for equity and equality of pay and also quality standards. So if you have staff that is trained at particular levels and they move between organizations, for example, then you can always trust that they, well, you should at least on paper be able to trust that they know particular things to a particular level and they are able to do the job to a particular specification. So I would go for the standardized approach for education.
So anybody else here that would support Sobeys viewpoint? Yeah? Lady at the back?
Bearing in mind the lady is about to speak, is paying her staff band 3 and is a part of an organisation that has a national programme for education.
Well, she may disagree. She may disagree with it.
I'm just putting some context to whatever Mandy objects to next.
No, so I completely agree with the gentleman's view in that in-house training can often be a lot better. And obviously I'm with Sterile now, but my previous organisation had their own in-house programme that I was actually part of delivering. So I delivered some of the modules, and it was a 9-module, 9-month programme that we delivered to our technicians that was very, very robust. No, it wasn't accredited, but it gave them all the skills they needed, including the history of decontamination and the reason why we do it and all the background. So I actually agree that a lot of in-house training programmes can be a lot more robust than some of the other training programmes that are generalised and not necessarily specific to decontamination.
And like I said, I don't disagree. I don't disagree. In fact, I have to attest to that one because my wife was trained on your training programme many years ago, and she is a very competent sterile services practitioner. So, yes, I do agree. And that's like I said, we can have these fantastic in-house training programmes. I'm not suggesting we do away with them, but there needs to be a nationally recognised framework.
And I think that's, it's one of the issues that we've got, and certainly, obviously, I was actually due to start an apprenticeship this month, but it's been pulled, so I can't do it now. And I know that Sterile do support technicians doing apprenticeships, but it's really hard when you've got 75 technicians to release. You can't release 75 technicians in one go to do an apprenticeship because you'll bring the facility to a stop. Yeah. And also, with the government funding and everything that's going on with that, to also pay for an apprenticeship for 75 technicians is also very expensive. So I think there needs to be something for all organisations that, if it has to be accredited, is accredited, but also is cost effective so that we can all get our technicians up to the standard without a massive cost impact on the businesses and the NHS.
So, I'll tell you what, exactly that. Some of the things I did at Manchester, so we've got 3 sterile services, 8 endoscope decontamination units, and I have an instrument management service at one of the South Side hospitals with this gentleman over there who's recently passed his technical certificate, even though he's never worked in sterile services. He passed with distinction, right, Mark? No?
I did.
You did. You did now. But he did very well. Anyway, so it is a challenge, you're right. And not having the levy really impacts because the apprenticeships, to fund that type of course, it's hugely expensive without the levy. So one of the things that we've done to address it is we have a small cohort each year, and we put them through the sterile services, the IDSE technical certificate, the level 3. Before we did that, so the first year because we didn't used to have a training budget at Manchester, believe it or not. Before I started, there was no training budget for decontamination staff. They were just left completely unsupported, uninvested. So I stamped my feet, created a lot of noise, and managed to get a very small training budget. What we did is all the decontamination facilities, whether it was endoscopy or sterile services, we spoke to education providers like Steris, like AVM, Decon Solutions, all those guys that do the City and Guilds qualifications, Eastwood Park. And we did a bit of a tender to identify if we had critical mass, a group package where we can get everybody to this base level principles of decontamination. So everybody has got a City and Guilds qualification of the basic principles of decontamination. So we did that for all staff, and then for the supervisory staff and managers, we made sure they all had the next, so it was level 1, then we made sure everybody else had the level 2. So that was the foundation. We got quite a good price on that because we had a lot of people doing it, and we were able to just do 2-3 day classroom sessions, and we could deliver that training en masse very, very quickly. But that's not enough. That wasn't getting us up to the required level. So what we're working on now, and what we've been doing over the last 3 years, is every year we have a cohort of 6 staff. Can't really do more than that, one, because I can't mentor more than 6 at a time, and they can't really release more than that off the shop floor whenever they need to come to my sessions, or we need to give them 20% of the time off the job to go and do the studying. So we do 6 staff a year, roll that through, and we try and hit that we get all those staff ready for exam within the 12 months. Cohort 1 didn't. We only had 2 people that were going through the exam. So we didn't quite hit the mark there. Cohort 2, pretty much everyone's ready for exam, and we've got to catch up with the remainder from Cohort 1. And then Cohort 3, they're in the process of doing that now. And that's how we're going to roll it through. It's going to take time. I'm not saying any of these things are going to happen overnight, but challenge of budgets, challenge of operational demand, we've got to find some mechanism of doing it. So that's the way we've tried to address it.
Sobi, do you want to come back on with your thoughts?
After this, I will keep my mouth shut, I promise. So we are not disagreeing the standardization and more training.
Yes, you did.
That is always good. You remember once we got NVQ, level 3 decontamination.
I do.
The main
But
reason...
then the TVQ got
TV.
pulled.
The main reason all that training initiative failed because we haven't got enough qualified assessors.
Yeah.
So that is the case. That's one point. Second one is that, I don't know, you heard about the project search. We are part of a project search program. That means we recruit people with the disabilities, mainly from autism spectrum. Mm-hmm. So that we can work with them and we adapt the training need according to their needs. I don't think so an external provider can do that for us. So these are the issues for the current offering. That's why, we never say no to any new training opportunities, any standardization. That's always good. But we are not there yet.
No, you're right.
Thank you.
You're right. And this is why I say I don't think any standardized program should replace what we do in-house, because we do some great work in-house. We do need to catch up. So for IDSC members, everyone's seen the change for the journal. We've seen how that's gone, and we've got the neurodivergence options now that helps people with ADHD, dyslexia, and it changes the visuals of the journal, so it can help people with those types of neurodivergence. We're going to roll that out to the certificates, so that when you view the context and the syllabus, you can pick if you have any of those neurodivergence, so it supports and aids in the learning. Now, the way that the technical certificate's designed is it's supposed to be delivered by your mentor or your manager. Your manager should really be your mentor. So, Sobi, Bev, in your department, you guys would be there, bringing up the junior staff and delivering that training. So in the same way that you already do with your in-house training, you support with the delivery of that education as qualified experts in your own fields. Yeah? That's the way we're doing it at Manchester, and that's the way it was all originally intended to be done. You're right when we talk about the apprenticeships, the lack of assessors. There's literally 2 assessors in the country, and they are not getting any younger. Both of them are now retired, and they do that as their part-time job, and you're both in your branch, so you know them. So that is a challenge. But I think one of the ways I've worked in Manchester, and my recommendation to the new Director of Education, is we probably come away from the decontamination apprenticeships, because if you actually look at the syllabus in them, you don't get any more knowledge of decontamination on the apprenticeships, whether it's a level 2, 4 or 6, than you do from the level 3 certificate. What gets you the increased levels is the other aspects, the management side and things like that. So one of the mechanisms we're looking at Manchester is level 3 and then progress through higher education diplomas in management and things like that. My suggestion to the Director of Education, I'm going to get shot in the foot because I'm saying far too much now, is that we probably look at developing, whether it's a certificate or diplomas in, specifically in decontamination, we tailor it. So your level 4 certificate would be aimed at supervisors. So you've got the underpinning knowledge, you look at what potentially additional information we need to have and training we need to have as a supervisor. Your level 5 aimed at production managers, so you start looking at process flow, how to organise a washroom, how to organise a clean room. Your level 6 quality managers start looking at 13485, including things that you'd get on a lead auditor course. And then your level 7 would be an ops manager, one where you go into a little bit more in depth about finance and budgets and things like that. And then you could have all of those qualifications that would lead you up to an 8A position. If you will hold all of them, you are a sterile service manager, because that is all the knowledge that you would need to have to run a department. And that's something that it's very much in the inception. I'm saying it to you now, and I only suggested it last week. So that's something that we are looking at with the changes that's happening with the apprenticeships and levy.
I think for me, it's something I'll go off piste a minute. We've never really been able to get a satisfactory degree over the line in medical device decontamination. We've had an offering through the University of Highlands. We've had this Irish offering that's on the table today. We've had Anglia Ruskin over the years. We've had Eastwood Park offer a foundation degree.
I can tell you why that is. It's because it's too niche. So a lot of universities, they've actually dropped some of their recently dropped some of their long-standing degrees and qualifications because there isn't enough take-up. Now, getting stuck on my own way, we're a very small industry with an even smaller uptake for education. So there's very, very few universities that are going to say, yeah, we're going to commit time and money to developing this degree and then offer that degree, because realistically, how many people per year are going to sit that degree?
So if you think in the UK, right, and we've gone from the technician rate now, we're going into the higher echelon. We've got ADs, no formal qualification. Yeah, you do experience, you do your engineering qualifications. You could be a chartered mechanical engineer, but that's totally different to decontamination sciences. You will have executive board decontamination leads. What do they know? It could be a director of nursing. What do they know about decontamination? Yeah, they may be brilliant at nursing, but what do they know about? So all these people, and look what we've talked about today: flexible endoscopes, ultrasound probes, microbiology. Yeah, we've talked about ergonomic flow pathways, innovations. We've talked about in one day. Look at the science we've talked about. Now, the finances is another matter, and I don't argue with that, Rob. You're totally right. It's about volume. But all these people need formal qualifications, yeah, to do their role. Like I send AD reports off to the designated person. They come back to me, and I can tell, what on earth is he on about? Yeah? Because it's a science in its own right, isn't it? I think we are missing a trick here, that we need perhaps a multidisciplinary approach to this. IHEAM, IDSC, CSC, IPS, etc. Perhaps even if we co-fund it, to make sure those upper echelon are qualified correctly.
Yeah,
because we can't, for the reasons you say, volume, we can't get anything that's over the line.
No. And universities are not going to adopt it.
Correct.
I have something of a tangent. So I'm all for kind of standardisation of job roles. But, I mean, Sobi alluded to in the past, the way we've seen in our area, other places get the Band 3 technician, is that they reduce the number of technicians. I mean, I think that this is going to be a common throughout the country. If we say that we have more technical people, people think you can do with less, especially with automation. So should we not, as an industry, be looking at safe staffing levels? It's difficult because there's a lot of variety in processes, but
there's
otherwise...
a lot of variety in process, there's a lot of variety in hospital. So again, you may get contacted in the next year or two. So the Department of Health has commissioned a private company to map out sterile services capacity in the UK. That project has started, and this is pure conjecture, this is not proven, so don't hold me against it. I think that is going to lead to the 2004 decontamination programme coming back on the table for the Department of Health, because that is the only rationale I could see why they would invest in doing this type of mapping nationally. Okay? Now, the mechanism they're looking at is how many washers, how many staff, how many trays do you produce? And they've got these formulas. And I looked at the document and I said to you, it's not that simple. Because I can have the dental hospital here with X amount of technicians, and say this technician can do 50 trays within a shift or 50 trays an hour. Now, compare that to this orthopedic hospital here, where that technician is going to do 2 trays an hour. Yeah? So the complexity of the instruments is different. And that's where you're going to have that challenge of staff numbers and autonomy and things like that. And I think that there's too much disparity between. So you look at. I mean, I look at the hospitals in my care board. Okay, we don't do neuro, we don't do spinal in Manchester. We've got 10 hospitals. Not one of those 10 hospitals in my responsibility does spinal or neuro. All of that goes to Salford. Yeah, and the big orthopedics that goes elsewhere. You know, you know how that's split up. You're the same. You don't do neuro at Bath. It all goes to Bristol, right? Yeah. And I think everywhere as far as from Southampton west, all neuro goes to Bristol. Yeah, correct. Yeah. Salisbury is your regional plastic centre, so they do more plastics and more specialties, particularly hands, than anywhere else. So you can't, even within hospitals, you can't compare. You're not comparing apples with apples, basically. There's this chain, there's this difference.
I agree, and that's the problem, because when we have this and it requires a Band 3 technician, absolutely fine. We're still going to get that pressure from trust boards to reduce. And when you're looking at where we go wrong, like the HSSIB, where we've gone wrong, the root cause is more often than not a lack of education, but it's the operational pressures where SSDs don't feel like they have enough power to say no, and they're so rushed.
I wouldn't say it's your SSD. And the decision maker, I mean, I would never recommend reducing the staff to upper banding. We haven't done that for our endoscopy. We presented the rationale. That was delivered to the divisional directors of that directorate, and they've taken that on. So that was their decision, but it was communicated to them in a way that this is standardised across MFT. Where that drive needs to come, it needs to be your decontamination lead. I don't know, because like John said, decontamination leads sit in a variety of roles. I think I might need to do that talk I did at CSC a little bit more openly in the industry for people to understand what a decon lead actually is and should do. But it needs to be your decon lead with your chief nurse, and your decon lead needs to remind that board that they are the authority. They are there to advise them. If you don't listen to what your decon lead says, and this is direct to your exec board, if they don't listen, they're opening themselves up to a regulatory compliance gap, and possible issues. Your chief nurse and your decon lead should be very, very close, and your decon lead should be able to present a rationale and a case to your chief nurse. Your chief nurse or DIPSI, they tend to carry the clout, and they're the ones who will support in convincing the board of what you need to do. That's how we did it in Manchester. That message got through, and that worked. And I'm not kidding you, no disrespect to Bath, but MFT, it's like turning an oil tanker. It's the largest healthcare provider in Northern Europe. It is an immense organisation, and there's several tiers of boards. To try and get anything done there is a task and a half. So I'd say if we can do it in Manchester and we can convince those boards, and trust there's several of them, you guys can do it in Bath. And
Yeah.
I'm happy to give you some input on how we did it.
No, I completely agree in principle, but I also think because we have a fairly decent relationship in Bath, but I see other hospitals and that relationship is not there,
Oh,
and
absolutely.
that influence is not there, and
Yeah.
trying to gain it is so incredibly
but
hard.
is that the problem, what Rob is saying, that it's not being escalated? Yeah? It's like moving a problem from your desk. It's somebody else's responsibility, and I see so many people where they don't want to escalate that because they see it as a position of failure instead of saying, look, you have to resource and fund us. We have to have training budgets. We have to, we need resource, because if we're not resourced, we can't do it. I know the lady at the back wants to come in there as well.
I've used the comment to my board before, not for this issue, but for a different topic, where I've said to her, and you've been quite open, and gone, look, I have reached the limit of my authority. I can take this no further. You have to step in and now take this on. And that's what John's saying. It's about the language you use and how you escalate, and just making that clear that we need to do this. I've done as much as I can with the seniority that you've allowed me or afforded me. Execs, over to you to make the decision, and then take it from there.
And we're not criticising Bath, by the way.
No.
Yeah.
I agree with what you say. It is, SSD is the lowest one. It's like they will always sort it out. And obviously going off a tangent from this, so many times I get a phone call at the last minute because they forgot to do something, or 37 cent a loan kit, and I need it for tomorrow. You've got to do it for tomorrow. And if we say no, then it's, well, this patient's going to be cancelled and it's your fault. And we never say no for no reason.
That's exactly what I said earlier. Sterile Services never sit there saying, no, we're not going to do it. We always say, we'll try as best.
Yeah, but the pressure is always put on us to do it. It's never, actually, we've messed up and we're going to have to delay this patient because we're not going to put the pressure on them. It is always, the pressure is on the SSD. However, the trust boards don't want to pay the SSD staff the higher banding for the work that they do. And I think the attitude needs to change really high up.
But are they aware of the problem? See? What I'm saying, if you guys don't escalate it, Datex's or
And
whatever.
this is what I'm saying.
Yeah.
It needs to be your decontamination lead.
Yes.
And I know, so when I was at Nottingham, I wasn't fortunate enough to be the decontamination lead. The decontamination lead there was the estates director, because in a previous role, he used to validate sterilisers. And he was quite open. He said to us, he says, all I know about decontamination is how to do a couple of tests on a steriliser from 10, 15 years ago. But this tends to be how it works. I see a lot of organisations where, are you on the exec board? Yeah, you're the decontamination lead. So everybody interprets the standards differently. And this is what I was speaking about at CSC last week, that trust boards, some organisations get it right. Some organisations go, well, okay, you're a sterile service manager, you can be a decon lead. I know one private hospital that made the decontamination lead. The lady was an ex-nurse who just happened throughout her career to start running an endoscope decontamination unit. She had 2 washers, and because she was doing something to do with decontamination, that hospital went, well, you're the decon lead now, without properly understanding the level of responsibility that they were placing on this individual and what the regulatory compliance of that individual should be, or what was actually accountable for if it ever went, to the High Court and things like that. So, firstly, there's a lot of education that needs to happen right at exec level about understanding what a true decontamination lead is, and we've tried to do that with the technical bulletin and explaining that. There's probably more of that to go, but it would be those individuals who are there to explain the nuances to the execs of why we need to do this and what we need to do.
Hi, I'm Laura from Blackpool Decontamination Unit. We currently don't have a decontamination lead. We haven't had somebody in position for a while. And I want to get cracking on this, but I don't know where to go with it. What would your advice be to where to go to get things started?
So when you say with what, cracking on with what?
With the
education,
with the
bandings.
education, we've got no training budget. Never have done. I've been fighting for funding.
Okay, sterile services or endoscopy?
Endoscopy.
Endoscopy.
Yeah.
So do you sit in with your GI medicine division?
Yes.
Okay, so the first port of call is going to be your divisional, your operations director for that division, your finance lead. I'd probably touch base with your head of infection control and hopefully try and get somebody through to your DIPSI. So your organisation will have a DIPSI. It's probably going to be your chief nurse. And they may be the person within your organisation that has accepted responsibility for decon lead role.
Okay.
Because they would the DIPSI is going to be ultimately responsible for infection control. Decontamination is one of the core pillars of infection control, so they might take that position on. But you need to start it through that and say, talk about the CQC. It's like playing scare tactics. You mention things like CQC, you mention things like regulatory gaps and reputational damage and patient safety, because we haven't got these competencies. And then that's when, unfortunately, that's what makes more senior positions start listening. But ops director, finance director, and then get to your infection control and your chief nurse, and just try and figure out a mechanism for putting a paper together.
Okay, thank you.
Being in Blackpool, you're in the northwest, so you are surrounded by a lot of organisations that have all got decon leads. They're all doing this, and they're all working towards it. I'd suggest joining your northwest branch. So Mike sits on that branch, and one of Mike's colleagues at work is actually the secretary of that branch. Robbie, who's the decon lead at Liverpool, he's the chair of that branch. And it's basically, they could guide you with the things that they've done in their hospitals and what's worked and what hasn't, and just have those discussions to try and direct you in the way that you need to go. That's what the branches are for, to shared learning over common problems.
Okay, thank you.
I think it's been a fabulous day, isn't it? We've had plenty of discussions. We've covered a great deal of ground there, guys. Yeah, I think the topics you guys engage in has been fabulous. The whole engagement with the exhibitors has been fabulous.